Recording in progress.
I actually think most of the others could see it because they have commented it as S. We'll continue with Brother Saj.
Excellent. Actually, next stage is unstageable stage, or we can number it as a stage 5 or unstageable stage. Already we discussed in stage 1, 2, 3, 4, everything we could see. But unstageable stage means we cannot see actually the wound. The wound is covering with a dark colored eshka. It's like eshka or a dark colored slough. That slough or eshka is on top of the wound, will cover everything. If the eshkar or the slough is removing means only we can identify that wound depth and everything. So this one is the unstageable wound. Next slide. Then while we are seeing one patient, what are all the things as a doctor or as a nurse, what are all the things we need to assess? First of all, we seeing one patient in a continuous bed-bound stage or continuous in a wheelchair stage. We on seeing one patient means that pressure-prone areas in such situation we need to assess. Having any color change or having any skin peeling is there or not, we need to assess. Next one, if the patient is already having the wound on that area at any stage also having the wound, we need to assess the pain on that area. If the patient is complaining pain or not, we need to assess. Then we need to assess the area of the wound, that location. Then if the wound having the depth means we need to measure the length, width and the depth of the wound. We need to measure the circumference. Then only we can identify again next visit that size of the wound and the depth of the wound is increasing or not, or it will decreasing or not. That if, according to our management, the improvement is there or not, we need to measure. So we need to measure the depth and everything. Then stage of the wound we need to assess. Then any exudate is present. Exudate means the profuse discharge from the wound, that is present or not. Any tunneling is present or not, we need to assess, because in third stage already I told on tunneling may will happen. We cannot identify how much length depth is there. We need to assess the depth of the tunneling and the direction of the tunneling, only just involving the superficially or not. Then we need to chart all these findings and we need to hand over to other. Then management. Always before doing the wound care, if we addressing the patient having pain means we need to treat the pain, then only do the pain management. First stage, if the caregiver is able to do the care for the patient means we need to educate them. Excellent education we need to give for the caregiver to give the care for the patient. Mainly if the patient is in the stage of incontinence of bowel and bladder means periodical change of diaper, periodical cleaning, that importance we need to educate them. And we need to involve them also for the proper care for the patient. So proper cleaning and a periodical changing of everything will reduce the risk factor for the skin peeling. Then stage 2, if suppose we seeing as a wound in stage 2 means we can use the normal saline for the cleaning and we can do the dressing and we can educate them for the wound cleaning and the dressing. Then stage 3, 4 and unstageable. 3 stages of wound if we see means if the wound having slough means if the slough removal is possible means we can remove the slough. Any surgical debridement is necessary for that wound means we can recommend that. Or otherwise, if we only can, if the slough cutting means we can do the slough cutting. Then after the slough cutting and other steps as same only, normal saline cleaning we can do. Homemade saline also we can use and we can promote the caregiver for using the homemade saline, because periodical continuous wound care needed patient means getting or buying the normal saline from outside means will burden for the caregiver. So we can educate them for preparation of the homemade saline for the wound dressing. Then if there is any foul smelling or malodor, if the patient wound having means, we can suspect the infectious sign. It's like infectious sign. So we can use the metronidazole. Actually, it's a tab form. We need to make it as a grind and make it as a powder form and mix it in the metrogel powder, already made powder. We can mix it in as a lubricant form in petroleum jelly. We can use for mixing it, and we can spread on the wound, and we can dress that wound by using that jelly form of metronidazole powder. Then, if the patient continuously having the slough on the wound area means slough area, we can use the debridase ointment, or it's we can use continuously up to the slough removal. We can use the debridase ointment. Then mega heel ointment also we can use in if the slough is not at all it's healthy wound means we can use the mega heel up to the tissue development. Next. Okay. Then if while we visiting the patient time, the patient side or room is having that much of foul smell, malodor means, we can educate them to use the charcoal under the bedside, because it is an antioxidant. It will absorb the bad smell. So it will reduce the smell in the room. So we can educate them. Then this type of wound, we don't use any povidone iodine solution or hydrogen peroxide like these solutions. We don't use normal saline only. We can use for the cleaning for the wound. Next. Then any surgery consultation is needed. Any if suppose we seeing one patient beds or stage 4, continuously we seeing on that situation only. If any plastic surgery consultation, if we suppose we feeling to recommend means we can recommend. Then negative pressure dressing or vacuum assisted closure technique. This actually this technique mainly under the guidance of the plastic surgeon only we will do, but we can promote the wound healing mainly the pressure sore area. Prolonged pressure sore means we can use this technique of dressing. Mainly the suction apparatus and the suction cap is needed. It will connect to the absorbent pad on that wound, and we need to maintain the pressure also. That negative pressure wound therapy will promote the it will avoid the collection of the exudate on that area. Periodically, it will suck the exudates, and it will promote the wound healing as fast as possible. Then already I told homemade saline and dressing items, we can educate the caregiver for preparing their home. First one, normal saline. Homemade saline, we can educate them to prepare. For that, we needed just take 500 ml of plain water, add 1 teaspoon of salt. Common salt we can use, boil it and mix it, boil it and cool and keep covered until it needed. They can use that homemade saline. Then gauze also. From market we can purchase the gauze, but continuously needed case means purchasing from outside that poor patient means they cannot afford. So we can promote them to use for old cotton sarees or dhotis. Cotton type material means they can use. They need to cut it into square pieces and they can steam it 30 minutes to 1 hour. They can steam it in idli maker. That in between they can place it and need to steam it, and they can use that cutted piece of cotton cloth with Vaseline or any liquid paraffin. They can apply on that and they can use for dressing the wound. as we are all know, prevention is better than cure. So how we are all going to do the measures for prevention of pressure sore or bed sore? First one, position change. Already I told prolonged position in one position means it will cause the pressure sore. So every 2 to 3 hours need to change the position for if the patient is in bed bound stage. So we need to educate the caregiver also to change the position every 2 to 3 hours. Both lateral position and supine position. So we need to, in between, they need to change up to the sleeping time. Then, if the patient is mainly the daytime spending in wheelchair means, majority time wheelchair spending patient means they need to every 15 to 20 minutes in between, they need to do one push-up with support of both hand on the handrest of the wheelchair. Just do one push-up, hold for few seconds, then they can again sit. So we need to educate that type of patient. If the patient is paraplegic means they will have the upper arm strength. So we need to educate, just do one push-up on with support of their upper arm. Then if the patient is having incontinence of bladder, means if it's possible for the catheterization, indwelling catheterization means we can do the indwelling catheter, or any urocondom is only just needed for the patient means we can promote them. So we need to manage the incontinence. Then in special surfaces means if the patient is prolonged bed bound in bed, directly mattress means only will cause the bed sore. Like that, some knowledge deficit in between the society is having. So many patients will purchase the bed sore or water, air bed or water bed, and will make like the patient on that. So if the patient is lying in airbed or water bed, it will not prevent the pressure sore. Even if in airbed or water bed also, that patient need to change the position. It's must. But risk, it will reduce. Comparatively in plain mattress, this airbed and water bed is comparatively, it will reduce the risk factor for the pressure sore, but position changing is mandatory. Then pillows and cushions. If the patient is mainly in lateral position means in between the knee, in between the foot, we need to give the pillows or any cushion for the adequate support. Next. Then nutrition, hydration and exercise. Adequate nutrition, every vitamins and minerals, everything we need to include in the diet. Then adequate hydration also we need to promote. Then exercise, not only the active exercise, passive exercise also we need to promote for the caregiver to do for the patient. Then massage. As a skin care, we need to promote them to do the massage by using white petroleum jelly or bioline and liquid paraffin, but using that massaging we need to promote. Then while doing the bed making time also, mainly wrinkle-free bed we need to provide for the patient for the for lying. Then proper nail care also it's needed, because if the patient is having itchiness and long nail means it will cause the scratch and it will cause for the peeling and other stages of pressure sore. So we need to do the nail care also. Then same point already we discussed only. We can, it's short as like S skin, SSKIN. So first one, S means supporting the surface. Already I told. Then skin inspection. Then keep moving, position changing. Then incontinence or moisture control. Means bladder incontinence means we will do the management. Then proper nutrition also. These are all the main things we need to do for the prevention of the pressure. Then engage the patient and family for avoiding the pressure ulcer. So we need to educate the family also. What are all the things they need to do for the patient for the prevention of the pressure sore? So we need to explain. Then we need to explain the importance of the thorough care for the patient getting. That importance we need to explain for the caregiver. Then for preventing the pressure sore, what can we do? Not only the caregiver, if the patient also can cooperate for the care, means both patient and the caregiver need to together do some of the steps for the preventing the pressure sore. What are all the things for prevention already we discussed? So we need to promote and we need to educate them the importance. Then patient information leaflets. What are all the mainly the pressure in here also pressure prone areas? What are all the things for the bedbound patients we need to do? Everything in their knowledge, for their knowledge in their language we will prepare on leaflet. Example I am showing this. Actually this one is in our mother tongue in Malayalam. We made one leaflet. So according to how often we need to change the position, in between, in every position changing time, what are all the comfortable devices we need to give for maintaining the position? What are all the things we need to access? Everything we just this diagrammatic representation we already presenting in Malayalam language. Like this on leaflet, you also can prepare and can educate the caregiver. Next. Next type of wound is a fungating wound or cancer wound. Cancer wound or fungating wound is actually due to the primary reason or any secondary malignant growth in the skin, which gradually it will burst and has ulcerated and difficult to heal. This type of cancerous or fungating wound will not heal. Then actually it will initially it will happening as like a nodule formation. That nodule formation will gradually develop as like this type of the fungating or cancerous wound. Next. Then pathophysiology. Actually already I told the nodule formation will happen on underlying the skin area. That nodule size will increase, enlarging of the nodule size. Then this nodule will apply on pressure on the underlying tissues. It will cause the capillary and lymphatic vessel supply, it will affect. Due to the affected capillary supply, or altered coagulation also will happen. In some cases, coagulant, it will affect the coagulant, means it will cause the profuse bleeding. In case disruption will cause any clot formation, means it will affect the blood flow also. So it will cause the altered coagulation or disorganized circulation on the blood capillaries or the lymphatic vessels also. Then tissue will become hypoxic, oxygen supply will decrease, and the necrosis also will happen on that area. This one is the Marjolin's ulcer. Marjolin's ulcer means it's a type of malignant stage only. Already, if the patient having on long-standing scar or a chronic wound, if the patient having, means that maybe it's a pressure sore or any venous ulcer or long-standing scar, chronic wound. That chronic wound, the malignant changes will happen. That's one is the Marjolin's ulcer. In that cases, we need to confirm by doing the biopsy only. Next. Then Marjolin's wound means already the patient having one wound. That wound in between already continuously we assessing the wound. Suddenly we see an appearance of mass in the wound. Then onset of patient will already the patient had not that much pain on that wound, but suddenly after seeing the mass in the wound, patient will complain as like having on wound pain on previously having the wound area. Then changes in the character, that exudate already, the exudate having means its volume and color and its type is changing. more drainage will happen. Then only we need to for doing the confirmation of like doing the biopsy. Next. Then already we seen the fungating wound or the cancerous wound. If the patient is having the cancerous wound, means these are all the 4 domains: physically, psychologically, socially, and spiritually. Patient will affect due to the cancerous wound or fungating wound. Next one. First one, physical. Physically, already the patient having the fungating wound or cancerous wound, patient will surely will have the pain. Then other one is the malodor. Fungating wound means that much foul smell patient and the family will feel. Then bleeding. Already it will alter the coagulation. So it will cause maybe the bleeding. Then that much profuse the exudate will happen, or in between the patient will feeling itching on that wound area. Then if the proper covering of the wound not at all happening, or proper dressing is not getting for that patient, means if the flies is anything is on that wound is lying, means it will cause the maggots. So another one is the communication difficulty. If the patient is having example CA buccal mucosa, that area, if the patient having any fungating wound or cancerous wound, means it will affect the communication ability of the patient, cannot communicate as freely. So these are all the physical suffering will happen due to the fungating wound. Next one is the psychological. Altered body image. Already the fungating wound is there after forming the nodule formation. So the body image already altered. Then sexuality of the patient will affect. Then denial. If patient only will refuse everything. So patient only refuse the family members or due to the disease condition. So it will happen. Then fear about the wound. Next in future, next day or next time, what will happen on my wound? Bleeding or pain, uncontrollable foul smell, anything will happen or not. Like that, fear about the wound. Then depression and anxiety. Surely they will have the anxiety about the wound. Then shame. Socially only they will isolate due to the shame. They need to cover the wound. They need to cover maybe the wound in the face, means they need to cover the face almost majority of the time. So they feel shame for facing the community. Then guilt also. If the patient already had any bad habits like chewing of any tobacco substance, if the patient is suffering means CA buccal mucosa, means they will feel the guilty conscience, because due to my bad habit only this will happen or not, like that. Next one. Okay. Next one, social. Socially, the family isolation, social isolation will happen. They will by self only they will isolate inside the family or inside the certain society. Then social stigma also, fear of contagion, because in my family members, any other family members will affect anything because of my wound. That social stigma or fear of contagion will happen. Then effects on family. Then already I told the sexual relationship and marital relationship, it will affect or not. Then spiritually means they according to the punishment, according to their religious belief, is it happen due to any punishment from God or a fear of death? Everything will happen spiritually also. Next. Then for this wound also, what are all the things we need to assess? First one, the wound location. Any if impaired the mobility due to the wound or not, then easily covering that proper covering on that wound is having or not, we need to assess the wound location. Then wound appearance and the surrounding skin of the wound also we need to assess, because profusely exudate is coming means that exudate will irritate the surrounding skin also. So periodical changing and proper cleaning of the wound is mandatory for protecting the surrounding skin. So we need to assess the surrounding skin. Then the any bleeding possibility is there or not, we need to assess. Then principle of management, as like the same principle only. First of all, we need to assess the pain is there or not. If the having pain means we need to reduce the pain. Then control the malodor or foul smell or infectious sign means we need to control. If we need to start any systemic antibiotic, if anything need means we need to start for the controlling order as a sign of infection. Then managing exudate, proper padding and a periodical change of padding we need to do. Then for minimizing bleeding and minimizing pain, first of all, we need to thorough soaking of the wound before changing the dressing pad. Then holistic care we need to give. Empathetic approach we need to do for the patient while doing the dressing and while doing the assessment wound time of all. Then empowering the patient and family in wound care. Importance and the step, what are all the steps we need to do the proper wound care without distressing the patient. What are all the things we need to do? We need to explain to the caregiver. Next slide. Then wound dressing. This already I told, this wound we cannot heal the wound. We need to maintain or we need to improve the quality of the life through the proper symptom control. So first of all, as same I told, empathetic care we need to do. Just then provide a thorough bath every day before dressing. If it possible means do provide a thorough bath. Then ensure the patient had a dose of any analgesic medicine already. If the patient is having means before the dressing, if the patient suppose need to take that pain medicines before dressing. Then use normal saline for the cleaning the wound. Then whatever the medicine need to do the dressing means select the dressing medicine also. Next one. Then for the minimizing pain, deep pain if the patient is saying as like aching or stabbing continuously, if the patient is having the pain on the wound means any systemic analysis already the patient is getting means suppose need to do on adjusting on that dose means we need to do. Then superficial pain if the patient is suffering as like burning, pricking type of pain on the wound area means we can locally apply the sensorcaine or injection bupivacaine. As like medicines, we can do the local application before 20 minutes of dressing time. Next. Then if the patient wound having the malodor means daily cleaning and a proper changing of the dressing. Then foul smell is having means we can use local metronidazole tablet, crushed and powdered form we can use. If the wound is very much in between the cauliflower like seems like a position of the wound means suppose if we need means IV metronidazole irrigation also we can do, because in between that area if we cannot use the metronidazole powder, because thorough cleaning means thorough rubbing it will cause the bleeding for the wound. So avoiding the thorough rubbing on that wound, so we need to avoid the powder form of tablet and use injection form of metronidazole. Then systemic antibiotics if it needed means we can start. Then frequent changing of dressing. Then for the room foul smell if needed means we can use the charcoal as antioxidant. This type of wound also we cannot use hydrogen peroxide or betadine like type of solution for the cleaning. Normal saline we can use for the cleaning of the wound. Next slide. Then bleeding. For prevention, prevention is better than cure. So prevention of bleeding, any anticoagulant medicine, if the patient is getting means we need to stop means we can stop or adjust the dose. Or while doing the changing the dressing pad, we need to thorough soak the wound, then just peel off. Otherwise, it will cause the bleeding. Then if suppose any mild bleeding is happening means apply local pressure on that area. Any sucralfate powder is needed for control the bleeding means we can use. Then another injection form of medicines if at all needed means tranexamic acid we can use. Systemic ethamlate if it need to continue for the control the bleeding means we can use. Then palliative radiotherapy also we can, if it needed for the control bleeding means we can suggest. Then if not at all, we cannot controlling the bleeding, means dark colored cloth also we need to place nearby patient. It will reduce the fear of bleeding by the patient and the family. Next. Then role of cancer therapy also. In cancer, mainly as we are all know, radiotherapy we can do. Then cytotoxic chemotherapy also. Because in chemotherapy, mainly the medicines we mainly we doing for improving the patient health condition. But in cytotoxic chemotherapy, majority we will do for controlling the multiplication of the cancerous cells. Then hormone therapy also, mainly see a prostate or see a breast patient means we can do the hormone therapy. According to that, we can control the hormonal production also. We can reduce the cancerous intensity. Then surgery also is if it needed means we can do mainly in the cancer as a cancer therapy. Next slide. Actually, this one is our last slide. This one is the maggots. Mainly the fungating wound if the patient is having. Proper covering of the wound is not at all maintaining, means if the flies will sit there and it will cause this maggots. Suppose if the maggots, for the prevention of maggots, we need to do the use of mosquito nets on patient lying area. Then maintain personal and environmental hygiene also we needed, as like proper and periodical changing of the dressing pad and cleaning of the wound is mandatory. Then if we suppose we seeing on our group of maggots in that wound area, means we can apply the turpentine. Don't apply the turpentine directly on the wound area, just soak it the turpentine in the gauze piece and just place nearby the wound area. It will, by using that, we can remove the maggots manually. Then wound should be covered with the dressing all time. Every time need to cover the wound with the proper dressing pad and periodical changing also mandatory for this type of wound. It will prevent the maggots production. Okay, by this slide, just end up in this topic presentation. Thank you.
Thank you, Brother Sajan, for such an amazing session on wound management. So we have few questions. I think we can take it up for the next 5 minutes till 6 p.m. and then we will proceed with the case presentation for today. So, Brother Sajan, there are a few questions in the chat. I would read it. The first question was, kindly repeat the dressing part with metrogyl ointment and gauze preparation.
Okay. Actually, I told for the wound dressing, tab metrogyl, we can buy it and grind it and make it as a powder form. That powder form of metronidazole tab, we can mix it in the petroleum jelly or biolin and make it as a paste form or jelly form. Then we can apply that jelly form of mixture of biolin and a metrogyl powder. We can apply on the wound. Next one.
So this is most commonly what we do in pallium also, like we crush, as Brother Sajan was saying, we crush the metronidazole tablets and then we mix it with biolin. We have biolin ointment as well as you all would know about the Vaseline petroleum jelly, which is available everywhere. So we mix it and make it into a paste and then apply on the wound. So this we specifically follow here, and many of the palliative care centers also follow this kind of wound management. So the next question is, how does water bed compare with air bed?
Both are using. Mainly in our hospital setting, hospital setting and our patient also, we mainly promoting the air bed, because if suppose in case any prick by a sharp it happening, means water bed means it will wet atmosphere. Air bed means it will not cause like that. So mainly we promoting air bed, and it's easily transferable also. If water bed means we need to drain it out completely, then only we can transfer. Air bed is comparatively easier than the water bed for handling.
Handling as well as cost-wise, I think air bed is little more cheaper when compared to the water bed.
Okay.
And as he said previously, water bed or air bed, whatever it is just going to reduce the risk of pressure flows. But mainly we have to educate the patient and the caregiver to do the position change adequately. Like every 2 hours once, they need to do the position change. Only then we can prevent the progression of pressures. So
Can I ask something here?
Yeah, please.
Regarding the airbed, no? So which airbed do you recommend? Because I have seen patients who are using airbed, but there is lot of shock because of the electricity power which is used for the airbed. Most of the some cases I have seen, they have got electric shock.
Till now we have used airbags, ma'am. So, but we haven't faced anything like that till now. And we don't know anything specific like brands because we buy it as a whole in Pallium. So as a brand, we don't know like which to promote and all that. But whatever is readily available in the market, I think we can buy that. Thank you for that question, ma'am.
But I have seen patients with this electric shock, using the patient who are using airbed.
Anybody would like to comment on that?
Ma'am, why should the patient get the shock? I mean, you mean to say the electric current?
Yeah, electric current. I have seen patients of electric shock with electric current.
No, but then what we can do, we can just fill the air beforehand and then to put the patient, when patient is on the airbed, we should not fill the air. That we can do, right? What is, brother, is there any comment of yours?
Yeah.
Madam, actually, airbed, it's having one motor. That motor only will adjust the air pressure on that air mattress. Having one motor and one tubing also. It will regulate the pressure of the air on the mattress, air mattress. So in between, if we switch off in that motor means air will go off. So proper maintenance of the pressure of the air on that air mattress, that plug in the motor is mandatory.
That means there has to be a
Ma'am,
particular...
you understood what he's saying. You don't have to put the switch off. The electric current has to flow if you want the proper application of the airbed. So you cannot just put the air in and then disconnect it from the plug point. The plug point has to be there.
I am sorry, I have got the bed, which we can do that. The facility is such that we can just fill up the air. We can remove the motor. And once you feel that there is, the pressure is not maintained well, then we can again fill some more air. I have got, a bed which functions like that. I don't know. I mean,
therefore, I asked which brands do you recommend where the patient will not get electric shock?
Are you asking about static electricity?
We are discussing about the airbed which runs on the electric current.
So, Dr. Nandini, I think we are a little more diverting from the topic as of now. So, we will take up question because we are short of time. So,
no, ma'am, it is not diverting. What I am asking is, we use for the bed sore, we need airbed and we need waterbed. Waterbed, I've understood. I want to know which are the airbeds which don't give electric shock and what are the different types of brands which are available, which we can ask for the patients.
What I can
think
do
this question will be answered
brands...
better by a person who deals with airbed, with who is the airbed dealer, and he may be having from them which is the best quality which will be suitable for your place. I think the topic is about pressure source and how to prevent it and stuff like that. We are not going into the discussion of finding out which are the safe airbags available. Thank you.
And Dr. Nandini, what I can do is I can check with the pharmacist team here and let you know like what brand we use here. Maybe I can do that for you. Thank you.
Okay, thank you.
Thank you. So we are short of time. So as of now, I invite Dr. Praksha Varnakar for the case presentation today. Dr. Praksha, are you there?
Yes, ma'am.
Okay. So you can start it.
Good evening, everyone. I'm Dr. Preksha Verinekar from Goa, and I'm going to present a case scenario on wound management. Next slide, please. My patient is a 67-year-old male. The diagnosis is type 2 diabetes mellitus with dyslipidemia with chronic non-healing venous ulcer on right lower limb. Next slide, ma'am. The presenting complaints are severe pain in right lower limb since 1 to 2 months, disturbed sleep since 3 to 4 months, and persistent discharge from wound since 1 year. Next slide, ma'am. History of present illness. The patient is a known case of type 2 diabetes mellitus and dyslipidemia for the last 10 years. The patient gives history of suffering a road traffic accident, which was a self-accident 10 years ago, following which the patient suffered a fracture in tibia of left lower limb. There is currently no complaint of pain, swelling, redness, or difficulty in movement of the left lower limb. The fracture was operated in Tertiary Care Hospital of Goa, wherein an implant was inserted and is left in situ till date. However, there were also 3 major wounds which had developed on the right leg, that is on the dorsal surface of the right lower leg, the medial surface of the ankle joint, and the anterior surface of the ankle joint. The patient later continued treatment at Urban Health and Training Center, which is close to the Tertiary Care Hospital, where the wounds were dressed regularly and cleaned with povidone iodine. The patient developed severe itching and redness around the wound 2 weeks after doing regular dressing with betadine, that is povidone iodine. And hence the patient was diagnosed as allergic to povidone iodine and was shifted to dressing with hydroheal ointment. Next slide, ma'am. The wounds on the right lower leg had delayed healing, and the patient was referred to Goa Medical College, wherein sloughing and debridement was done. Following this, wounds A and B, that is the ones on the medial surface, healed over the next few months. The patient is unaware of the exact duration. However, the wound which was on the anterior surface of the ankle joint which was initially smaller in size, that is 4 by 4 centimeter, gradually progressed to increase in size, which is discussed later. There is persistent pain sensation over the wound throughout the day, which aggravates when it is cleaned during dressing. There is also, the pain that is described by the patient is throbbing or aching in type. There is also discharge associated with the wound, wherein the dressing gets soaked and it also causes staining of the clothes, also associated with foul smelling odor. Patient also gives history of developing swelling associated with redness around the wound, which was 2 months ago. It was treated with antibiotics, broad spectrum, type amoxiclav 625 mg thrice a day for 7 days. And the wound was cleaned using hydrogen peroxide solution and packed with metronidazole ointment for a total period of 7 days. Currently, the daily dressing is done with hydrogel ointment, and the patient follows up regularly for daily dressing at Urban Health and Training Center. Next slide. On examination, the general examination shows that the patient is conscious, oriented, comfortably sitting in the dressing room, looks anxious, restless. The vitals were within normal limits. Systemic examination also was within normal limits. Local examination of wound on the right leg, a single large shallow ulcer measuring almost 25 to 15 centimeter on the medial aspect of right lower leg, which is extending from the lower margin of the medial malleolus of right ankle joint to the junction of mid and lower 1/3 of right lower leg. The findings of inspection were confirmed on palpation. Edges are raised, everted, margins are thin with growing epithelium. Floor is covered with plain granulation tissue with occasional traces of blood. Base is hard and fixed to deeper structures, and seropurulent discharge is noted. Next slide, ma'am. There is no local rise in temperature. However, tenderness is present while performing dressing of the wound. The surrounding skin also shows bluish-black discoloration. Skin is rough to touch, dry and eczematous. Scars of the previously healed wounds are noted. There are no varicose veins, sinuses noted. Regional lymph nodes, inguinal lymph nodes are not palpable. On peripheral pulse examination, the pulses were felt in both right and lower limbs. Next slide, ma'am. The patient's wound culture and sensitivity reports was sent, but they could not be procured. However, histopathology biopsy report shows findings suggestive of squamous cell carcinomatous growth. Nests of squamous epithelial cells with abundant eosinophilic cytoplasm and a large vesicular pleomorphic nucleus with variable keratinization is noted. Doppler of the lower limb is within normal limits. The patient is a diabetic. HbA1c was 6.6%. The fasting and postprandial sugar levels were within normal limits. Serum creatinine is 1.3 milligram per deciliter. Total cholesterol is 145 milligram per deciliter. Next slide, ma'am. The patient belongs to class 3, that is middle class, socioeconomic class as per modified BG Prasad socioeconomic status classification updated for 2022. The wife of the patient suffered a cerebrovascular accident 3 years ago. She is currently having left hemiparesis, following which she is non-ambulatory. So assistance for her daily routine activities are provided by the patient himself. The patient's only son is unmarried and unemployed. There are only 3 members in the family currently. Patient also complains of not being happy with his quality of life as the wound over the right leg is painful, disrupts his sleep, and discharges constantly throughout the day. Patient is also unable to do odd jobs which he wishes to as a result of his condition, as it causes constant staining of clothes and also gives a foul smelling odor. The patient also gives history that if he dies, he would not be unhappy about it, and he doesn't expect much from life ahead. Next slide, ma'am. The patient is currently on tab silostazole, that is Stilose 50 mg BD, tab atorvastatin 10 mg HS, tab glimepiride 1 mg BD. Patient's metformin was stopped because of the rising creatinine levels. Patient is also on tab Deflon 500 mg BD. And as of now, the patient's wound is dressed daily at the center. Cleaning of wound with normal saline is done, and hydrogel ointment is applied. In case, in situations if slough is present, the wound is soaked in Uzol for 15 to 20 minutes and cleaned with hydrogen peroxide. This is with instructions that were given from tertiary care hospital, the surgeon that he was consulting with. Next slide, ma'am. The patient is burdened with chronic persistent pain and sleep disturbances. He is also clinically depressed and has a poor quality of life. And the patient is caretaker of his wife and son, and loss of his life may cause financial distress to his family and may further result in worsening of quality of life of the family. So to summarize, the patient is an elderly male with type 2 diabetes mellitus and dyslipidemia, presenting with chronic non-healing venous ulcer, that is Marjolin's ulcer, with histopathological findings suggestive of squamous cell carcinoma on right lower limb belonging to class 3 socioeconomic status as per modified BG Prasad socioeconomic status classification updated for 2022. So the points to be discussed in today's class are: do we need to provide palliative care for this patient? What are the problems faced by this patient according to you? How can we effectively manage the wound in addition to the current management that is provided to the patient? And what all can be done for this patient and his family to improve the overall quality of life? Thank you.
Thank you, Dr. Praksha, for that amazing presentation with the pictures too. And we have the discussion points for today. So I could see Dr. Sujamanu has raised her hand for long. Do you want to comment something? So we will move into the discussion points for today. So the first question was, do we need to provide palliative care for this patient? So what do you people think? You can comment in the chat box or you can unmute and just say whatever you have in mind. Hearing to this case story, what do you think? Whether this patient needs palliative care or not? So I could see many yes from Akshay, Sheetal, Shweta, and Dr. Mahrooq Parvez. Okay, so definitely for this patient, we need palliative care because he is in serious health-related suffering. So in terms of addressing this patient also, we need to think from the total aspect on the principles of palliative care, that is physical, psychosocial, emotional, as well as spiritual. So these are the certain things that we need to consider with respect to this patient. So second question is, what are the problems faced by this patient? So what are the problems? We could see that this patient has a chronic wound, which was a Marjolin's ulcer turned into a squamous cell carcinoma. And this patient has severe pain. And we could see so many psychosocial concerns that Dr. Praksha has mentioned in the PPT. So obviously, these are some of the problems faced by these patients. So I could see Dr. Madhumita has mentioned that non-healing ulcer, yes. Financially, yeah. And there's a physical disability, yes. And Dr. Jyoti has mentioned non-healing ulcer with active infection turning to malignancy. And financial problems, social problems, yes, very good. And pain, yes, he is not able to work. So that is something which is going to affect him emotionally. And then we have psychosocial concerns, and he's been in this wound for so long. Obviously, he would have thought a lot about this wound. Why is this not healing? What is happening to me? All these questions would have already come within him. So he would have got into depression, and yes, not being able to work and contribute to the betterment of the family. Maybe if he is a primary breadwinner, because of this wound and pain, he wouldn't be able to go for the daily work. And that is why his family gets affected, children gets affected, and also the body image is affected because of the wound. How would he carry himself when he goes to work? Will someone accept a person who has wound to come for a job, like for example, to work in a restaurant or something like that? Personally, we don't prefer, right? So all these things might be a problem for him, obviously. And someone has commented anxiety and insomnia, definitely because of the pain, because of thinking about all of this, so much anxious and going into sleeplessness. I could see very nice comments from all of you. Thank you so much. And sleep disturbances and mental health is affected, obviously. Brother Sajan, you want to comment something on this question? I think they have covered most of the answers. Very wonderful answers you have given. So these are some of the issues, as I said, and also the question within himself, like why God has given me this. If he is a sole believer of, God, then obviously he would have all these questions in mind. Why did he give me this? And otherwise, also we have that spiritual component within ourselves, asking ourselves why this is happening to me. So Dr. Salah has commented motivation and psychosocial support and proper counseling can be given for this patient. Yes, obviously. Would leg elevation help in this case? It will, so Brother Sajan says that it will reduce the edema in this case. Because since it's a wound, so wound leg elevation might help to reduce the edema in this case. So then we can move into the third question. So the third question is, how can we effectively manage the wound in addition to the current management? First of all, Dr. Praksha.
Sorry. When it comes to pain management, till now the patient was being given, initially he was given paracetamol, which over time the pain would not subside with it. We would put him on Dolo 650 BD to TDS. Eventually we shifted him to ibuprofen 400 mg TDS. But this is as per the drugs that are available at our center. He was not keen on buying medicines from outside, but we counseled him, but to the extent that he was ready to buy only Deflon, which is also not available at tertiary care hospital. My question is to the fellow participants, like, should he be shifted to step 3, that is, should he be put on tramadol along with paracetamol, for better pain management, which will also help with his sleep disturbances, like a sustained release formulation, which tramadol, by the way, is also not available at our center. It was available initially, but over time that is also not available. So we even tried aceclofenac plus paracetamol combination, but that also doesn't work. So if you all can advise something about that.
Anybody wants to unmute and answer to her question? Or you can just post in the comments too. Dr. Praksha is asking a very important question. She is saying she has tried only step 1 because she doesn't have step 2 or step 3 in her setting. So she is asking whether we need to move this patient to step 2 or step 3. So that's a very, very important question, because in the first slide, we could see in the chief compliance, she had mentioned that this patient has severe pain. So obviously pain needs to be managed adequately. So Dr. Praksha, what I can tell you is Goa, there are few centers in Goa which has fentanyl patches, which has, tramadol. So what I can do is I can share Pallium's directory with you that can help you so that you can connect your own patients to some other center from where they can procure opioids. So I think opioids will really help this patient. First thing is we need to do a proper pain assessment. I think you would have already learned that class where we do the proper pain assessment of O, P, Q, R, and ST. So onset of pain, site, P for provocating and palliating factors, the quality of pain, the radiation component of pain, the temporal factors, the severity. All these things needs to be assessed, and then we have to decide whether this patient has to go into step 2 or step 3. Sometimes the patient will move directly from step 1 to step 3 because he might be in severe pain. So he can be started on morphine or fentanyl, whichever is available in our setting. And if he is coming to you with severe pain, then most probably we can try a morphine trial for him and then decide on the dose, whichever has to be given as an oral dose. So that is one thing. And also, if he has a radiating component, and if you think that neuropathic pain is the main feature which is attributing to even more pain, then we might need to start him on certain adjuvants like amitriptyline, pregabalin. So there are many other adjuvants that we have, like which will actually improve the quality of life of this patient. So with respect to sleep, because we could see in the history that this patient has insomnia, has been in sleeplessness for many years. So what we can do is, one thing is to address pain, because pain might be one reason why he is not sleeping at night. If you ask that question to him, then he might be able to tell us what is the reason for his sleeplessness. And also the thoughts, the emotional thoughts that he has, that will be there definitely. So you have to address that. You can put him on something like clonazepam for a short course, like when you are starting morphine or tramadol for pain, you can also give clonazepam, benzodiazepines, or whatever you have in your setting for a few days and see whether that is helping him with the sleep. So that is one thing which is very, very important. And I could see many comments on the same, like considering long-standing NSAIDs may be nephrotoxic. Yeah, definitely. Even we wouldn't advise NSAIDs for long. Whatever we use here is we give it only for a short course. So we give it for a short course to see whether it is giving the relief. If it's not giving, then we are going to cut it there and then move to the next step. So that we need to keep in mind. And Madhumita also says step 3 would be advisable. Yeah, because the first point said the patient was in severe pain. And then there are a few comments we need to go to step 3. And also Dr. Suresh has commented we can try gabapentin plus or nortriptyline preparations. And opioids is a good option. Tab morphine should be started. Yeah, I think you people have all learned a lot and you people are commenting so well. So that is how we need to manage pain adequately in this patient. Apart from pain, we also need to think about, because whenever we think and treat pain, we also need to think about the other aspects of pain, that is the emotional, because emotional, psychosocial, as well as spiritual concerns. Maybe we can connect him to a psychologist. So a psychologist would be able to give him a good counseling, would be able to assess whether this patient has anxiety or depression. And also we can talk to the family members to know what they feel, because many of the times, I don't know whether this patient was recently diagnosed with squamous cell carcinomas. We don't know the insight of the illness. We don't know at what level their understanding is. So we need to sit and talk to the family as well as the patient to have a deeper understanding of what he is undergoing. So all these things will actually improve the entire quality of care for this patient. And also with the wound dressing. So with the wound dressing, in this case, I would say if the patient has a severe pain, then what we can do is we can soak the dressing for a few minutes with NS, and then we remove the dressing. And then if there is severe pain, you have to schedule the analgesic dose just 20 minutes or half an hour prior to your dressing. That will relieve pain. Other way, what you can do is you can also inject bupivacaine as a like a local application. For example, what we use here is bupivacaine as well as lignocaine. So lignocaine is 5% plain. What we do is we make it into 10% by mixing it with 5 ml of NS. So that becomes 10 ml. And then based on the size of the wound, if the wound is very large, because in the photo I could see the wound has a large surface area. So you will need 10 ml. So that what you can do is you can just soak that in the gauze and then you can place it over the wound so that it will give pain relief. And after that, you can start with the dressing. Brother Sajan, you want to comment on that?
Same only.
Yeah, and moreover, we use bupivacaine also. Bupivacaine is available in concentrations of 0.25% as well as 0.5%. So what we use is, if we are using 0.25%, then we take 6 ml of 0.25% of injection bupivacaine and mix it with 4 ml of NS, making it into 10 ml. Or if we are using 0.5%, since the concentration is little higher, then what we will use is like we will take 2 ml of 0.5% of injection bupivacaine and mix it with 8 ml of NS. And then we use it for local application. And when I worked previously in Kozhikode, I have seen there they use ketamine, injection ketamine, 0.25 to 0.5 milligrams per kg, which can be mixed with honey because ketamine is very bitter. So what they give is they mix it with honey and then give it sublingually and wait for about few drops, which will be given sublingually. And then we make the patient wait for about 15 minutes so that once the pain reduces, then they will start with the dressing. So these are something which very little things, but when we keep this in mind and do the dressing, it becomes really comfortable for the patient also. Any questions? So someone has asked, can you please give details of Pallium India Center in Goa? So I would like to say that Pallium India doesn't have a center in Goa. We are based only on Trivandrum and we have our setting only in Trivandrum. But we have our directory. You can go into the website www.palliumindia.org as Shri Priya has already mentioned that in the comment. You just click on this and then you can see in the bottom of the website, you will see go to directory. So when you click on the directory, then it takes to one page where you will see all the states, list of all the states. What you can do is you can click that state. If you're from Karnataka, just click Karnataka. You go there, you will get the list of palliative care centers in Karnataka. If you're from Andhra, you'll get from Andhra. And also, you will get the details and contact number of these centers. And also, you will get to know whether they have morphine availability at their center. So these are the details which are available in the website. And I think Dr. Praksha will be really very helpful for you because I know a person, Dr. Felero from Goa, who had spoken to me previously because she was working in a setting. I just don't remember the foundation where she was working, but she was using fentanyl, morphine and all that, which was available in Goa. You can just open the clinics which are available from the directory and then you can just connect to them.
Sorry, doctor, you said the 3 types of anesthetic usage in while doing dressing. The first thing I missed, what did you say? I'm so sorry.
Okay, so we use for whatever we use is one thing is the bupivacaine and injection lignocaine. We don't use both together. We use either bupivacaine or lignocaine. For some patients, bupivacaine will be very helpful. But for some people, when we try bupivacaine for local application and see, they will not have good pain relief. For example, before a few months, we had a patient with the same history, like a non-healing ulcer, which was actually a vasculitis, and she was having intense pain. So we were forced to go into the highest level of management where we used injection ketamine and lignocaine for managing her pain. In that case, what we used was initially we used injection bupivacaine for local application. We took 0.5% of injection bupivacaine, 2%, 2 ml, and then mixed with it with 8 ml of NS. And then what we do is we just soak it in the gauze, and a few of the medicine we just apply also, and then we soak it in the gauze and then close it, and then keep it for about 10 to 15 minutes for it to act locally. And then we will do the dressing. So that is one thing. The second thing is injection lignocaine. It also helps. So lignocaine, what we used was we took 5%, 2%, right? 2%, I'm sorry. So 2% of 5 ml of injection lignocaine, and then we mixed it with 5 ml of NS to make it into 10 ml. So this you can actually adjust depending on the surface area of the wound. So you can just instill this, or you can just soak it in the gauze and then keep it over the wound, leave it for about 10 to 15 minutes. And then if you do the dressing, it becomes very comfortable for the patient. The third thing that I mentioned was injection ketamine. So injection ketamine is not something that we use locally, but we give it as sublingually, which I have not used in Pallium India per se, but when I have worked in a different setting in Calicut, I have seen consultants using injection ketamine, which is 0.25 to 0.5 mg per kg. We calculate according to the patient's weight. And since ketamine is very bitter in taste, what we do is we mix it with honey and then we give it sublingually, wait for about 15 minutes, and then we start with the dressing. Clear?
So higher concentration of lignocaine, like 4% lignocaine are also available, 20% are also available. That also I think we can use locally.
I think we can use it, but whatever we have used is 2% plain.
Sure,
we have not used the mixed combination which comes from adrenaline. We have used plain lignocaine 2% for instilling.
Sure, thank you very much. Thanks.
So someone has asked another question, ma'am, what is the difference between wet and dry dressing? When to shift from one type to another? Brother Sajan, would you like to take this question? What is the difference between wet and dry dressing? So wet dressing is something where I mentioned, like for example, usually we tell the patients to take bath and then we start the wound dressing, because already it becomes little soaked so that it is easy for us to remove the dressing. And by the term wet dressing, what I meant was like, if it is dry, for example, the dressing is all dry, you did it yesterday morning, you're going to do it in the evening. Obviously, it will be little dry outside. Then what we do is we just remove the gauze, just the outside one, and then you instill NS. You instill NS fully and then soak it for about 10 to 15 minutes for it to become wet, so that when you remove it, there is very little pain. So that is the term I meant as the wetting the dressing. Clear?